Welcome, everybody. I'm speaking with my partially regenerated recurrent laryngeal nerve, still hoarse. I know we're in the middle of a respiratory disease epidemic, particularly among children, and I appreciate the messages I've got from the department with Dr. Mercer's help. But I'll pretend I'm Dr. Rodriguez and call aboard. I'm here. Dr. Mr. Walker. I think you're muted, Michael.
I'm sorry.
I think you're muted.
Okay.
Michael.
Yes. Thank you. I'm here.
Dr. Cheek.
Present.
Dr. Mercer. Dr. Cheek.
Present.
Dr. Mercer. Shin.
Present.
Mr. Tobar.
Shin. Present.
Okay. Tobar. I think we have enough to begin the meeting. So welcome everybody, and let's introduce Dr. Toomey. Oh no, first of all, are there any notes on the old minutes from the previous meeting, or do I have a motion to accept them?
So move.
Second, anybody?
Second, Dr. Cheek.
Okay, all in favor?
Second.
Dr. Cheek.
Okay, all in favor? Okay.
Aye.
Dr. Toomey, the floor is yours.
Aye.
Okay.
Yes, thank you.
Julie?
We're hearing echo, and I don't know why that is. I don't know if it's on our end. What's that?
No, they need the other personnel need to mute.
Okay, so everybody needs to mute, I think so. Great. Well, thank you so much. I just wanted to say, I hope you see in the agenda today that we really took seriously a lot of the issues that you raised in past meetings and followed up on them and got some answers to make sure that we were addressing concerns and also taking advantage of opportunities we have now to make some changes and programmatic changes. So yeah, thanks to Dr. Mercer and Dr. Cheek, who brought up issues related to CMV and neonatal screening. We have some presentations today about how, we propose that this is going to be rolled out, but there's always other opportunities. And also thanks to you last session, I think it was also you, Dr. Cheek, you asked about influenza. Well, there's just a great deal of updates to give on the status of influenza now in the state. And we look forward to those updates, both from Dr. Drenzik as well as Dr. Millman, if there's some other issues related to vaccination. Also, thanks to you all and your interest. Actually, it was Dr. Curran, you actually asked about harm reduction partners. That email should have gotten out to you in the last several hours to update you on where we are with those harm reduction partners and to identify not only that we have this list, but also I think we're looking for opportunities to expand that. Dr. Rustin and I just a few minutes ago were in a meeting. We're talking about how we can share even Narcan with some of our partners out in the community doing vaccinations. So, we're looking for opportunities to really strengthen this opioid work.
I got the email. It's terrific.
Yeah, I thought it was a really good update that we're following up on. But last but not least, again, a shout out to Dr. Cheek, who I don't know what time I talked to you that evening, that you, although we knew the hospitals here, particularly CHOA, was packed with kids with respiratory virus, I don't think we fully appreciated the impact this was having, certainly in Columbus and some of the other hospitals around the state, and the transport issues, which is uniquely our role because of EMS. I shared this with the governor's office and DCH. Now they're taking some into consideration some issues around reimbursement. That's outside of our wheelhouse, but I says we can take action on those things that we do have ownership of, and we did, and worked over the weekend and got those letters out. And my understanding is there's implementation already in areas. And one of the issues you raised was the hospitals holding on to older children. And that was a recommendation that did go out statewide with the agreement of the hospitals. We didn't want to blindside the other hospitals that this was something that was coming. And then at a time when all hospitals are seeing their respiratory capacities challenged. So again, thank you all for the work you gave us this last month. And I think it's really been an important and productive opportunity for us to strengthen our programs. And so with that, let me turn it over, unless you have some questions, to our influenza and other challenges that we're dealing with.
Thanks so much, Dr. Toomey. Thanks for the introduction. It's a pleasure to be with you all this afternoon. So for a change, we're actually not going to talk about COVID and monkeypox today, but we're going to talk about influenza and a little bit about RSV as well. So can I have the first next slide, please? So again, I thought it would be helpful if we really just kind of set the stage about our flu season and about how flu surveillance is done. So let's start out again, as we've experienced in so many years, flu is always changing. It's a tremendously complex disease, and it can be very difficult to predict from season to season. It will always remain for us a significant cause of morbidity and mortality really around the globe. And one thing about flu, again, just as a reminder, flu surveillance is a little different than, for example, COVID surveillance, in the sense that individual influenza infections are not reportable to public health. That is really just not a feasible strategy. Most people with flu are not laboratory confirmed, or at least many are not. So it becomes very impractical. But we rely upon flu surveillance and a variety of ways to look at flu activity, really to inform our control and prevention efforts. It's the same as any other surveillance as far as the foundation of prevention and control. When we're talking about flu season, it's really, very traditionally defined as the very beginning of October through May. However, we've really been seeing overlap of flu season, so early, late. So really, we can see flu anytime during the year. Next slide, please. So when we're talking about flu surveillance, it's important really to understand that our primary goal is really not to document every single case, as I mentioned before. That would not be possible. But it's really important for us, kind of in a big picture, to determine when influenza activity begins, when it peaks, where it's occurring, what viruses are circulating specifically, doing a virologic surveillance, and also to determine the severity of these infections. That can change, kind of depending on what virus is circulating. And it really helps us target who's most at risk for severe infection, so that we can, again, target vaccine as appropriate. The other goal of flu surveillance really is just to be sure that we can detect any new flu viruses that emerge. All in all of this is used to inform our control and prevention efforts. Next slide, please. So when we're looking at flu surveillance, we're not just counting every case, as I mentioned before, but we're putting together pieces of the puzzle so that we can kind of get a full picture of what flu activity looks like at any given time. So as I mentioned, we look at a variety of indicators. I'll just briefly mention them. You'll see them as the slides progress. But again, we look at lab characterization of flu viruses. We look at really the proportion of outpatient visits for influenza-like illness, which is defined as a fever, cough, and sore throat. We look at that both in outpatient settings, also in ED settings. We compare kind of levels of influenza like illness to baseline levels. We look at the percent of flu tests that are positive. And we also look at the more severe outcomes as well, like hospitalizations, deaths, and also outbreaks. Particularly, we see them in institutional settings. So these are really the components or the pieces of the puzzle that tell us what's happening with flu, whereas we don't really need to count each and every case. Next slide, please. So now what I'd like to do is just take a few slides and go through essentially a snapshot, if you will, of the national flu picture, and then the picture here in Georgia, using and illustrating it with some of those same indicators that we just discussed. So first of all, let's just take a look at the national flu snapshot. This is a map of the US that really looks at flu activity. And what we mean by that is it really compares in a given geographic area, the proportion of visits for influenza-like illness relative to non-flu season. Compares it over a period of years. So you can end up with a flu activity level ranging all the way from minimal all the way up to very high, depending on this comparison. So what you see here in this map, it's really very telling. The southern United States, and also now really kind of the mid-Atlantic states as well, have very high flu activity. And again, that real dark maroon color, dark purple, and kind of the darkest red, those are the highest activity levels in a geographic area. This has been rising for a period of almost 2 months now, and has really began and continues to rise here in the southern US. If you look at, again, for example, the Pacific Northwest, just as an example, or the very northern part of the US, we really are seeing still minimal or low activity. This is not unusual in a flu season. We really can see strong geographic differences. But again, it reminds us here that especially here in the Southeast, it started very, very early. And because it's circulating so early, it ends up informing, again, our efforts to promote vaccine, because it takes a few weeks for vaccine to become effective. So again, looking at these activity levels really help us in order to try to target that as well. And when we look at the national flu picture just as well, that's where flu is occurring. What about what viruses are circulating? About 75% of the flu viruses that have been characterized so far in the nation have been influenza A, H3N2. And again, this is the predominant strain so far. And again, we have seen H3N2 seasons many times before. But again, they have a tendency to be more severe in regards to hospitalizations and deaths for the very young and the elderly as well. And if we just kind of take a look at some of the other flu indicators nationally, about 4% or so of all outpatient visits were people that had ILI, and about 9% of the tests for flu have been positive. And when we're looking at hospitalization rates nationally, it's really just starting to increase. However, this early in the season, and we're really just a few weeks into the technical flu season, even though we've been seeing flu for 2 months. Again, what you compare the hospitalization rates, it's never been this high nationally this early. As far as the last time it happened was in 2010. So that was, again, one of the pandemic years, 2009, 2010. So again, so we're beginning to get indications that this indeed may be a very severe flu season, not only a very early one. Next slide, please. I wanted to sort of turn now, that was our national snapshot. I want to just turn to our Georgia picture. And again, it'll be kind of similar indicators that we're going to use, but I wanted to highlight for us again, that same, sort of color scheme about flu activity across the state. We have had flu activity at a high level since mid-August, so really very early, and technically before the flu season, quote unquote. And we've actually had very high, the flu levels remained high for about 5 weeks or more, and now is actually at the very high level. You can see kind of this purple color. And when we're looking at our viruses that are circulating in Georgia, all the viruses that we have seen so far have been influenza A. We've seen very, very little B at all. And the majority are, again, as it was the case nationally, are H3N2 as far as the strain goes. Our activity in Georgia is really ramped up in the sense that, look at this, the percent of positive flu tests is about 18% compared to 9% nationally. So you can see, in these high activity areas, it's, the chance of a flu test being positive in somebody that has these symptoms is very likely. And we also are seeing that the proportion of outpatient visits for people that have influenza-like illness here in Georgia is about 10% this week. And this, I haven't seen a 10% proportion this early again. And we looked back, same thing, not until the most recent was the 2009-2010 pandemic year. So the proportion of visits is very, very high. And the baseline, just as a comparison, kind of at the threshold level, is about 3% normally. You kind of see people that can present with ILI, really any time of year. So 10% is a dramatic increase. So all of this just illustrates for us, again, both the early and potentially severe nature of this flu season. Next slide, please. So we often also get the question, so we know we have very high activity in Georgia, but is it occurring all around the state, or is it in pockets? Well, the answer to that question really is, if we look at the data, and again, it may be a little bit hard to see this, but you can get an appreciation, certainly, if you look at where Georgia is just above Florida on this map. You can see that really dark maroon color in the wide part of Metro Atlanta and North Georgia. That's the highest activity that we're seeing. It extends down to Macon, Columbus area as well. And then if you look at the more of the eastern side of the state, that's red. That's like a little bit less, but it's still high. And that is, kind of the Augusta, Savannah, kind of metropolitan areas as well. So we do see it all around, but of course, there's some variation geographically, and the higher population areas, we're seeing more as well. Next slide, please. So that is the activity levels and the where it's occurring. What about who is most affected? We'll look at outpatient visits first. And when we look at our outpatient visits, it's very clear that the vast majority of outpatient visits for influenza-like illness have been among the young. And in these graphs, you can see that it's both about 25% of all visits have been among young children, 0 to 4, and 50% of the visits have actually, encompassed children and also young adults as well, 5 to 24. That's the age range that they look at nationally. So if you look at that green line there that's circled, you look at how much higher that is relative to, kind of those bottom lines, the blue and the pink. Those are the individuals that are, kind of over the age of 65. So really, we're seeing a predominant distribution among children and young children as well. So it really underscores the importance of flu vaccination in this population. Next slide, please. If we take a look at, that's the ILI visits, but if we also take a look at hospitalizations, we also are, again, we're seeing increases as well. we really look at hospitalizations that are lab confirmed, and we only look in Metro Atlanta. It's really difficult to do it all around the state. But the data we have really have shown that flu hospitalizations have nearly doubled over the last 2 weeks. And about 30% of hospitalizations were among those older than 65. We're really seeing, again, a more even distribution of hospitalizations among age groups. But again, the highest one, which again is a little different than the visits, where we really saw a high proportion in children and young children. About 30% of our hospitalizations were in those older than 65. And this can change as the season moves forward as well. And our overall hospitalization rate here in Georgia is about 10 per 100K, which is really high. The national level is about 3 per 100K. And that CDC was saying is the highest that they've seen this early in 10, 12 years as well. So far this year, we've confirmed 2 flu-related deaths. Both of them occurred in individuals over the age of 50 years. Both had significant medical comorbidities. Interestingly, the number of flu outbreaks in institutional settings continue really to rise and accelerate. We documented 58 flu outbreaks just last week. That was up from the previous 2 weeks where we had 5 outbreaks, flu outbreaks in each of those weeks. So we're really seeing a large increase in outbreaks, and very consistently, half of them were in schools, school settings, and half were in long-term care facilities. So again, as we think about, it really, again, highlights and underscores for us during these H3N2 years, it's really important to ensure that these most affected populations, the young and the elderly, are vaccinated and protected as much as we can. Next slide, please. And again, just to highlight, for influenza prevention, again, the annual vaccination really remains the very best method for preventing seasonal flu and protecting against serious outcomes like hospitalization and death, and is recommended for everyone over the age of 6 months. Flu vaccine is not perfect in the sense that it does not prevent every single flu infection, but it does a remarkable job in protecting these very vulnerable, young kids, elderly adults, individuals that have comorbidities that will make them at higher risk for complications from flu and severe outcomes. The flu vaccine this year, as true of other seasons, is quadrivalent. It contains 4 flu strains, 2 influenza A's, including H3N2, including H1N1, and then 2 different types of influenza B. We have a tendency, at least historically, to see influenza B infections a little bit later in the season. This season has been different in many ways so far. So whether that holds true later, that's why we will continue to do our virologic surveillance as well. I just wanted to highlight and remind everyone that this flu season, one thing that is new is that individuals over the age of 65 are recommended to get one of the high dose flu or adjuvanted flu vaccines. There are 3 of them available. But again, no matter what, it's most important to get a flu vaccine. Even if you can't get that one, it's really important to ensure that everyone over 65 gets a flu vaccine as well. As I mentioned before, it can take a few weeks to reach maximum immunity. So if we're really getting this really early flu activity, it's important to ensure that we're vaccinated as soon as possible. But flu prevention, of course, always relies upon all of the other kind of standard pillars of respiratory virus transmission, such as staying home when sick and hand washing and respiratory etiquette. And that's why, again, as we were thinking about how this season is so much different than what we experienced during the pandemic years, with everyone really practicing these prevention pillars of masking, hand washing, staying home if you're sick, and respiratory etiquette, we had very, very, sort of low flu activity, again, as a result of that, of those pillars as well. So I think that's why we're seeing at least some increases, but there can be a lot of other factors that can drive, kind of viral transmission. So the bottom line is to get vaccinated. Next slide, please. I just wanted to mention one quick thing before we conclude. I'll shift gears from flu. I just have one slide about this. During the course of this really high flu activity that we've experienced so early, we also experienced large increases in transmission of and infections with respiratory syncytial virus, or RSV, in Georgia. This is a respiratory virus that can be very serious or even deadly in young children. Those under 12 months, babies are really at the highest risk for hospitalization or severe outcomes. And really, we typically see RSV season peak in winter or even late winter. I mean, we are very much, sort of way off the usual peak. It's very, very, very early this year. And it's also similar to flu in the sense that we don't count each and every case. It's not possible to do that, but we use the percent of lab specimens that are positive, and that can help us look for trends over time. And if you look at this graph, I really just, kind of wanted to highlight for you, if you just look at that blue line there, we had really high RSV activity. It began even in the end of August, beginning of September, very, very early. And we had these tremendously high peaks. The baseline or threshold for RSV is the dotted line down by the red. And so it's very low there. We had about a 20% positivity rate during, sort of mid-September, early in mid-September, and it started to go down in the succeeding weeks. And I think that, again, we may be looking at some consistent declines in RSV. This past week, we were down to a 4.6% positivity rate, which again, I always like to hold for some definitive trends. We might want to give it a few more weeks just to be sure, but it looks like we may be experiencing some declines in RSV activity while flu continues to increase, especially among the young. So at the point where we were having these huge positivity rates of RSV and young children hospitalized, flu is just starting to ramp up as well. So having sort of these dual infections really was a tremendous burden on our hospital capacities, as we have mentioned earlier, but hopefully perhaps RSV activity will be continuing to decline as well. But no matter what, even though there's not a vaccine for RSV, it's a strong reminder that, again, there are a lot of other viruses, respiratory viruses that can circulate and co-circulate with flu, and that we have to remember that, some of those, again, typical, sort of prevention pillars are appropriate, especially for young kids as well, while we see other viruses circulating. And I think the next slide is my last one, and I'll just my closing comments are similar to my beginning comments, is really that no matter what, we can always expect infectious diseases such as flu. However, they're always unpredictable. We're experiencing this very early flu season this year, but we can be assured that by conducting strong and having strong infrastructure for surveillance and epidemiologic investigation, we can target appropriately those that are at highest risk and prevent and control these diseases like flu. So I want to thank you so much for your attention, and I'm happy to answer questions if we have time, or if you want to hold them for later, but it's a pleasure to have had this opportunity. Thank you.
Are there any questions or comments? Thank you very much. It was terrific. Once again, you have a tiger by the tail. This time you have 3 of them. Are there any comments? Dr. Cheek?
There we go. Just had thank you to the department for bringing this to the highlight of where we are and where we've been. And unfortunately, I'm hopeful that maybe we're getting better, but we certainly have in my area have been inundated, as well as all the other children's hospitals across the state. I do want to say a very public thank you to the department, all of those that worked hard, and to Dr. Toomey. And she, I don't know, I didn't see it on the agenda, but to bring up just what they've done to help with transport. We all know that transport is very different for a 6-week-old, a 6-month-old, a 6-year-old, and a 16-year-old. And I think we're beginning to bring that to the forefront to help all of our EMS services and all of our hospitals come to understand that better. So although it's been a harrowing situation in some circumstances, it's definitely an opportunity for improvement. And I think those improvements are already in the works. And so I appreciate, as Dr. Toomey said, I know the department because I got several emails from her, worked hard over the weekend to make all this happen. So thank you very much for that. And we'll all hope that everyone gets their flu shots and we have less of a burden for the public to have to deal with.
Thank you. Any other comments or questions?
Dr. Kern, this is Dr. Rodriguez. I'm sure you could hear me. I
Yeah.
apologize for user error earlier. I could not get myself off mute or entered the wrong number. But I agree with Dr. Cheek. We have seen a huge increase in our patients being hospitalized, and it's stressed our system to capacity, and transports and just bedding patients has been very difficult. I'm glad to see that the RSV is basically dropping as far as the incidence, and I wonder if some of that it has to do with the vaccination. But my question to Dr. Dresnick is, do we have any idea the percentage of the population that is vaccinated in the state of Georgia for the flu vaccine?
Dr. Rodriguez, I actually don't have those data in front of me as far as currently, what our coverage is. I'm sure we have some initial estimates. Maybe Dr. Millman knows, or if not, we can for sure get this to you all. So.
Yeah, I don't have an estimate for what the statewide coverage is right now. So that would be something that we would need to look up to try to provide that information for you.
We'll get that to you by email.
Thank you. Thank you.
We know it's not high enough.
Yes,
Right,
yes.
never is.
Yep.
Any other comments or questions? Then we'll go to Tina Turner.
Thank you, and greetings, Commissioner Dr. Toomey and Chairman Dr. Curran. My name is Tina Turner. I am the Deputy Director of Child Health Services, and on behalf of Maternal Child Health and the Health Promotion Division, I am here to provide you all with a brief overview of the Early Hearing Detection and Intervention Program, as well as our plans to provide CCMV, congenital cytomegalovirus training and education to providers and families. Next slide. The Georgia Early Hearing Detection and Intervention Program, as we refer to as EDI, has been a public health program since 2001. In 2014, early hearing was added to the newborn screening rule 51155, which mandated hospital screening and reporting for every infant. The purpose of the program is to provide statewide screening and referral system, provide linkages to appropriate intervention, as well as provide technical assistance and training for hospitals, physicians, audiologists, early intervention, and public health. Next slide, please. Some general EDI protocols in Georgia include initial hearing screening prior to discharge, one follow-up screen as an outpatient, diagnostic evaluation, early hearing orientation specialist visit, enrollment into early intervention and support services, and transition to educational services and support. The EDI Georgia program, as well as other EDI programs throughout the nation, also engage in a national benchmarking program, which consists of, it's called 136, where infants are screened within 1 month for their screening, and within 3 months, they are provided a diagnostic evaluation, and within 6 months, they are to be referred to and enrolled in early intervention. Next slide, please. We have seen a slight increase in the number of babies identified with hearing loss before 3 months of age. With this slight increase, we have made sure that our district EDI coordinators have been provided with the resources and information they need and technical assistance. Our EDI program also provides one-on-one technical assistance to audiologists as well. And in coordination with our EDI evaluation team, the EDI program also provides quarterly performance improvement reports to the district coordinators as well to support with this increase in daily operations. Next slide, please. So in achieving these goals, babies are screened at birthing hospitals prior to discharge, and an automated screen result, pass, fail, or refer is produced. Technicians, nurses, audiologists perform the screen. Only 2 screens are allowed before discharge. A final screen, hearing screening status at discharge is reported to public health through SENS, which is the state electronic notifiable surveillance system. Next slide, please. So there is a district follow-up coordinator in every district as of 2009. They work with birthing facilities, families, primary care physicians, and audiologists. They work to enhance service delivery to meet the overall goals of the program in a timely manner, and they provide technical assistance when needed. Next slide, please. Diagnostic evaluations are completed by a licensed audiologist, either in a natural sleep nap study or with sedation. Providers are mandated to report results to DPH within 7 days of testing, either through a web-based reporting directly into SENS via the audiology portal, or through a paper surveillance form or report. Next slide, please. Thank you. So once an audiologist selects yes for permanent hearing loss, an automated referral via an encrypted email is sent out to 4 different locations. One being the district EDI coordinator, who then provides facilitates care coordination. And then to the referral is sent to Babies Can't Wait and Children with Medical Services. The next encrypted email is sent to the EDI team lead, who then requests a GIT number from the Department of Education, and that is a testing ID number. And the other email is sent to Georgia Pines for the early hearing orientation specialist visit, and who is one of our partners, and another partner receives an email, Georgia Hanson Voices, who is our family to family support partner. Next slide, please. So we're going to talk a little bit about congenital cytomegalovirus and the plans that the department has to provide training and education. Cytomegalovirus, as we refer to as CMV, is a virus that infects people of all ages. If you're pregnant, CMV can cause a particular concern because the infection can be passed on to the baby. If a baby is born with CMV infection, it is called congenital CMV, CCMV. 1 in 5 children with congenital CMV will have a permanent disability, such as hearing loss or developmental delay. Next slide, please. So the department has focused on 2 goals in providing training and education related to congenital cytomegalovirus. The first goal is to train all applicable hospital providers, screening personnel, and district staff on how to educate families and caregivers of infants who fail and/or refer their newborn hearing screening for 1 or more years prior to hospital discharge regarding CCMV as a potential cause for not passing between December 2022 and August of 2023, we will be developing training materials, which will include brochures as well as video, utilizing some national previously vetted material to develop the video and the materials such as CDC's material, as well as the National Center for Hearing and Assessment and Management. And after the development of the materials, we intend to post that on our website and make it available to hospital providers, personnel, and district staff. We will also engage our stakeholders in the development of the materials, as well as promote the materials through memos that will go out to our stakeholders and our providers, as well as the Georgia American Academy for Pediatrics and the Georgia Academy for Family Physicians. Those memos will support us in promoting the materials, as well as engage in the community. This goal, as well as the second goal, will be evaluated continuously, and we plan on posting the training video and the materials in July of 2023. The second goal is to provide education for families and caregivers of infants who fail and/or refer their newborn hearing screening for one or both ears prior to hospital discharge regarding CCMV as a potential cause for not passing. April 2023 through August of 2023, we intend on creating these materials and making them available to families and caregivers and posting it on our website as well. In April of 2023, the Newborn Screening Advisory Council will be having a spring meeting, and we will be presenting our training and educational plan to them as well to keep them informed and engaged in this process. There will also be frequently asked questions being produced for the providers' use to assist them in educating families. Next slide, please. So if you need more information about the EDDI program or our plan, you're welcome to contact me at the information above, or Dr. Culpepper, who is our early hearing detection intervention team lead at the Georgia Department of Public Health. And you see her information there above too. If there are any questions, are open, and I thank you for this time.
Thank you, Ms. Turner. Are there any questions for Ms. Turner?
Thank you so much, Ms. Turner. I'll ask a question, please. This is, as we know, with all infectious diseases, education is where we start, educating the public, educating our providers and all our healthcare. So I think this is a great opportunity for a great start. I might have missed it when we talked about referral and education of our technicians who are providing the test. Are there any plans for targeted screening in the hospital for those children who fail the hearing test?
Targeted screening for CCMV.
Yes, ma'am. Since we know that 1 of every 200 babies are born with congenital CMV. Now, fortunately, only 1 out of 5 of those will have sequelae. But but identifying them early is such an economic issue for the state because of the potential of early intervention and subsequent hearing loss. So are there any plans once we've identified the defect? I know there's a plan to refer. Is there a plan in the hospital for targeted screening?
So right now, I can provide you with a short response. In 2019, this was presented to the Newborn Screening Advisory Committee and to provide research to see if we will move forward. And we are in the process of developing another work group to look into this issue to see if we will decide to do targeted screening in Georgia. So I don't have a definitive answer for you today. That is my response.
Well, thank you. I'm glad that a group is being put together because I do think that if we look at across the nation, we are have not implemented targeted screening, and the majority of states have. So I appreciate the fact that we are putting together a study group.
Dr. Cheek?
Yes, this is, thank you so much. And like I said, I think just to highlight this issue is so important, and thank you for doing that. I concur with Dr. Mercer, not just early intervention, but, early antiviral sometimes can alter the course of CMV infections in young children, and anything we can do to improve their outcomes and have them be better than they would be if they weren't given medications or had early intervention, I think is just a huge positive for the state and especially for the children and those families. So I would strongly encourage, and I'm glad you have a committee already looking at this, but I think once this child does test negative, the sooner we get the idea that we ought to be testing and looking to see if he has CMV, to make those decisions. If there's treatments that need to be made early, we know the earlier the treatment, the better the outcome. Additionally, do we have in the state any real numbers of an internal audit of the number of babies that fail the hearing screen, and then subsequently at what time are they cleared for a hearing screen? In other words, so baby fails 2 tests in the hospital, baby goes out to the world. Do we have some data that says by another 2 weeks or 2 months that test is returned, now it's passed? And also, do we have an internal audit that says, okay, we've reviewed now all the newborn state screens, which is wonderful. The hearing screen is on the bottom of that now. I just see so many of those newborn state screens that I routinely get at 2 weeks. And lots of times they'll say the hearing screen not available or not input. So do we have where are we percentage wise in making sure those hearing screens are put on the newborn state screen? And where are we in terms of making sure that those babies that fail have had a normal test by, say, 1 month of life? Do we have those numbers?
So luckily, I have brought the Eddie evaluation team with me today. I believe that he is on the line for any specific data questions. Maybe not. He may not be. And this might be a question that I might have to get back with you on, if that's okay with you.
That'd be great. And if we don't have them, I mean, that's fine. But I think that's a really very needed area that we need to make sure that the babies that fail coming out of the hospital in another 2 weeks have had a passing test.
Okay, well, great. Thank you. I understand he is in a meeting, but he's not able to speak at this time. Some technical issues. So certainly we'll get back with you. Thank you so much for your interest and concern.
Thank you. These are very important points. And unlike COVID and RSV and influenza, these important CMV complications fall under the radar screen. Most people don't know about them until they have an affected infant. So thanks so much for doing what you're doing, and I applaud the effort to evaluate it.
Thank you.
Now we have Tracy Kavanaugh and Megan Andrews.
Tracy Kavanaugh, I'm the perinatal hepatitis B program coordinator, and I'm going to be co-presenting with Megan Andrews, and we're going to be talking about the updated prenatal testing requirements related to viral hepatitis. Next slide. Hepatitis B and hepatitis C are reportable in Georgia. These conditions are required to be reported to public health within 7 days of identification. The perinatal hepatitis B related conditions are hepatitis B surface antigen positive pregnant women, and then perinatal hepatitis B exposures. The perinatal hepatitis C conditions are hep C infected pregnant women, and then hep C infected children less than 3 years of age. Next slide. Hepatitis B virus and hepatitis C virus can be transmitted from an infected mother to her baby through contact with infected blood or body fluids at birth. In utero transmission is rare, And then perinatal hepatitis B can be transmitted horizontally, as blood can live on a surface for up to 7 days. Next slide. In years 2018 through 2021, over 4,000 chronic hepatitis B cases were identified in Georgia. Of those, 25% were females ages 13 to 47. In the same years, there were 511 acute hepatitis B cases reported in Georgia, and 21% of these acute cases were females ages 13 to 47. The graph on the left shows the chronic and acute hepatitis cases combined for females ages 13 to 47. The axis on the left indicates the number of chronic hepatitis B cases, and that correlates with the blue bars. The axis on the right correlates with the red line, which shows acute cases in females ages 13 to 47. And then the graph on the right shows hepatitis B infections in females ages 13 to 47 by race and diagnosis. The light gray color represents white, which accounted for 72% of the acute cases in females of childbearing age and 11% of chronic cases. The darker blue color represents Black or African American cases and accounts for 19% of the acute cases and 36% of the chronic cases. And then the darker gray represents Asian, which accounts for less than 1% of acute cases and 42% of chronic cases in Georgia. Next slide. The risk of perinatal hepatitis B transmission is impacted by the mother's hepatitis B e antigen status at birth. So infants that are born to a hepatitis B e antigen positive mother and hep B surface antigen mother have about a 70% to 90% risk of becoming infected if post-exposure prophylaxis is not administered. If the mother is hepatitis B surface antigen only, then the risk is about 10% or less if prophy is not administered. And then for our infants that do become infected, 90% will become chronically infected and 25% may die prematurely. And there is post-exposure prophylaxis for hepatitis B, which consists of hepatitis B immunoglobulin and hepatitis B vaccine given within 12 hours of birth. Is about 94% effective in preventing perinatal transmission. Next slide. In 2020, Georgia identified 253 hepatitis B exposed births. The highest concentration of the hepatitis B births occurred in Metro Atlanta, which accounted for 71% of all of those exposed births. And 75% of the exposed births were born to mothers who reported being born outside the United States. Next slide. The Georgia Perinatal Hepatitis B Prevention Program tracks or case manages infants born to hepatitis B surface antigen positive mothers until the child completes testing or is 24 months of age. This program is federally funded through the immunization program grant, and every state has a perinatal hepatitis B prevention program. And each public health district has a perinatal case manager who is responsible for identifying hepatitis B infected pregnant women, ensuring that HBV and Hep B vaccine are given within 12 hours of birth, ensuring that exposed infant completes the hepatitis B vaccine series, and they coordinate post-vaccination serologic testing at 9 to 12 months of age. Next slide. Post-vaccination serologic testing is recommended at 9 to 12 months of age for hepatitis B exposed infants. Testing consists of hepatitis B surface antigen and hepatitis B surface antibody. In Georgia, 83% of our infants completed the PDST and developed immunity in birth cohort 2020. Even despite our best efforts to ensure exposed infants complete interventions, infants still do become infected. And this is why the PDST is such a critical intervention. And Georgia has identified 9 infected infants in years 2011 through 2020. Next slide. So now we'll quickly transition into perinatal hepatitis C. The risk of perinatal hep C transmission is impacted by the mother's HIV status. So 7.2% of infants born to mothers infected with hep C who are HIV negative have about 7.2% risk. And then infants born to mothers co-infected with Hep C and HIV have a 12.1% risk. And then the outcomes for perinatally infected children are about 20 to 40% will spontaneously clear the infection by age 5. And then 50% may go on to have chronic asymptomatic infection, and 30% will have chronic active infection. And differently than hepatitis B, there is no post-exposure prophylaxis for hepatitis C. And of course, there's no Hep C vaccine. Next slide. One of the most significant consequences of the opioid epidemic has been the rise of hepatitis C infection among reproductive age persons who use IV drugs, including pregnant women. So in 2018 through 2021, there's been over 41,000 chronic hepatitis C cases identified, and of those, 17% were females of childbearing age. In the same years, for acute hepatitis cases, there were 739 cases, and 17% were among females ages 13 to 47. The graph on the left shows chronic and acute cases. The blue bars are chronic cases, and then the red are acute cases. The year 2020, data reporting was down due to COVID, so that's when there's a drop in the cases, but then it picked back up in 2021. Also, of the acute cases, female acute cases, 30% of these cases reported injection drug use in their lifetime. The graph on the right shows Hep C infections in females ages 13 through 47 by race and diagnosis. The gray color represents white, which accounted for 85% of acute cases in females and 45% of chronic cases, and the overall Hep C case total. The orange color represents unknown races and accounts for 5% of acute cases and 42% of chronic. And then the light gray represents Black or African American, which accounts for 6% of acute cases and 11% of chronic and the overall Hep C cases. Next slide. In 2018 through, click one more time, please. In 2018 through 2021, Georgia identified 2,172 mother-infant pairs who have a history of hepatitis C in our state notifiable disease database. Of these births, 662 infants were born to a mother that had a Hep C RNA positive lab result within 365 days of the child's birth. Next slide. Georgia began case management of hepatitis C exposed infants in 2018. We don't have a single staff member dedicated to perinatal follow-up. We have 7 in-kind state DPH staff who work on the project and are responsible for case management of the infants. And Georgia also does not receive specific funding for perinatal Hep C case management. Our goal is to notify the pediatric provider about the exposure and test as many exposed children as possible. Next slide. The table on the right shows the testing outcomes for case managed infants in 2018 through 2021. Of the case managed infants by DPH, 39% were tested, 37% were not infected, and 2% were infected. So in total, we have identified 24 perinatal hepatitis C cases in Georgia for that time frame of 2018 through 2021. 11 of those cases were case managed and 13 were not. Next slide.
Hey, everyone. So I'll take over for the updates to our rules and regulations regarding prenatal testing requirements. So there were national updates made to prenatal testing recommendations that then prompted us to update our rules and regs in this space, particularly on the Hep C testing. There was a recommendation during COVID in 2020, so it did take us some time to implement it, but we did implement those recommendations into our rules and regs. You can go to the next slide. So the the rulemaking process requires the proposed regulations to be posted publicly and allow a public hearing where anyone can come comment on the proposed regulations, and then an adoption after that. So these changes went into effect on August 31st of this year. They went through that formal rulemaking process by DPH and our general counsel. And you can see on the right-hand slide, that's our flyer, one pager that's been broadly distributed. I'll talk a little bit more about some of our outreach in that space. And the next slides are zoomed in of that content, so you guys can see a little more clearly on what we covered. But at the first prenatal visit, we expanded the testing requirements to include Hep B and Hep C for all pregnant women. Previously, syphilis and HIV were required at that prenatal visit, and that's in Georgia code. It wasn't in our rules and regulations. And then third trimester, we added Hep C testing for women who are at continued risk or with a known exposure to Hep C. And then at delivery, we added testing for Hep B for women who were not tested prenatally, who have signs or symptoms of Hep B, or are at high risk of contracting Hep B. And then also added Hep C testing for women that had no record of being tested prenatally. Next slide. And as I mentioned, this is a zoomed in portion of the flyer that's available on our website that breaks down the serologic testing requirements for pregnant women that were added to our rules and regs. So you can see them here. There's like a baseline test required for all of 3 of these conditions at the first prenatal visit. You can go to the next slide. For the third trimester testing, the regulations do require HIV testing before 36 weeks and syphilis at 28 to 32 weeks. There is some exceptions that are available in Georgia code, and they're reflected in our rules and regulations as far as women who were tested earlier in the pregnancy. And then Hep C testing in the third trimester for women at continued risk or with a known exposure to Hep C. Next slide. And here's the testing requirements at delivery. For all of the conditions, if a woman presents at a birthing hospital and has no record of a test for any of those conditions, they do need to be tested as soon as possible at the birthing hospital. So appropriate measures can be taken following the birth of the child or during delivery. Next slide. As far as outreach, and I talked a little bit about this, we did a lot of work with external organizations, both prior to posting the rule while we were developing the updated language, as well as after the rule went into place to educate providers. So we worked with the Georgia Hospital Association to discuss the impact to birthing hospitals, the OBGYN Society, obviously, family physicians, the American Academy of Pediatrics, the Medical Association of Georgia, and even the Department of Community Health for the impacts to Medicaid pregnancies and potential costs to reimbursement. So all of those organizations were contacted prior to the rule being posted, and we took a lot of their suggestions into account and made pretty significant changes to the proposed rules and regulations to account for those recommendations. I think Dr. Rodriguez, you were even on a call through one of those organizations to help give us guidance on this. So it really was a collective effort. As far as outreach post adoption of the rule, the Dear Colleague letter to the right went out to all medical providers from Dr. Toomey explaining these changes. We distributed that flyer widely to all of these organizations. And we are also hosting webinars, echo sessions in October and November to train providers on these changes. Next slide. And that's it from me. Tracy and I can answer any questions that y'all may have if there are any.
So Dr. Cheek, you have your hand up. So I have a question, a couple of questions. One of the remarkable things of the last decade is that hepatitis C is curable. And the couple of things I don't know, and one is what the recommendations for treatment of hepatitis C during pregnancy is, whether the medications are recommended during pregnancy. And second of all, the status of the antiviral drugs for newborns. But it strikes me that this program is set up to prevent transmission of hepatitis C and to allow for the cure of hepatitis C. So if you can answer the questions and then also talk about whether you know whether people are being treated, if not during pregnancy, then after pregnancy.
Okay, for pregnancy, there's not currently a recommendation to treat pregnant women with antiviral treatment. What you would do is postpartum, link them to care and hopefully link them to cure, because like you said, hepatitis C is curable now. There is not a treatment for children younger than 3 years of age. It's only approved for 3 years of age and older.
But it's not approved for use in pregnancy, right?
Not currently. There's some studies where they're doing that, but there's no current recommendation at this point.
How about follow-up and treatment of women after they deliver?
At this point, we don't have the capacity to do that through public health. We're mostly just focusing on the child. That's something that's on our wish list with funding. Hopefully we can have a postpartum linkage to care person to help get those women treated so that they're cured and can't pass it on to any future pregnancies or others.
I would think that would be a very important part of the program.
It's an extremely important part that we hope, we can fulfill, because there's definitely a need.
I think this, excuse me, Dr. Kurt, I think this is an example of, I think we can get with our nursing director, who works very closely with the OBGYN Society and others to see how we can accomplish this very effectively. And I think we can work on this really before we meet next.
Very good. Any other comments for Tracy and Megan from the board?
I think the information was excellent, very well presented, and lots of information for us to digest. How has the progress been on third-party payers covering all of this extra screening? Has there been any pushback on that?
We have not heard any pushback at this point. When we spoke with Medicaid, there was, they did not have any concerns as far as increased costs. They told us most of those screens were already covered or should already be covered. But I have not heard anything at this point from any private providers, private insurance companies with concerns. But if those issues do arise, I'd love to hear from whoever's having that problem so we can try and address it.
That's great. Any other comments or questions on this? Thank you, Tracy and Megan. It's now time for the board to give general comments or general thoughts.
Thank you. I enjoyed the meeting today and the extra information.
Thank you, Dr. Mercer. I agree. Are there any other comments?
Likewise, I felt like it was very informative. And for the first time, we kind of talked about other things other than COVID and monkeypox. So that was certainly enlightening. Thank you very much.
The public health problems keep on coming, Michael. Any other comments? Our next meeting is January 9th. I can't remember whether it's in person or by Zoom.
In person,
It's in person.
yes.
Look forward to seeing all of us together and healthy. Everybody who hasn't gotten their flu shot should get it. Get your COVID booster and stay healthy. So thanks. Is there a motion to adjourn?
May I ask, is it January the 9th or January the 10th?
What's that?
I bet I looked at an old calendar.
It's whatever that second Tuesday is.
That's January the 10th, isn't it?
Well, there you are. We're looking at, we're yesterday's calendar. We haven't bought new 2023 calendars yet, but we will before we meet.
The budget thing.
Yeah, that's right, kids. I'll check with our CFO to make sure we have some money in our budget for updated calendars. No, it's January 10th. Thank you.
Pointing that out.
January 10th. Thank you. Pointing that out.
January 10th it is.